boa tarde a todos. Retomando, então, nossas palestras deste primeiro dia, convido agora o Dr. Tim Watson, da Inglaterra, que irá abordar o tema Aplicações clínicas, demonstrações e estudos de casos, abordagens funcionais para NMES. Por favor, Dr. Tim Watson.
Thank you. Thank you to the committee for inviting me and for IBRAMED for being good hosts. And this is the first time in Brazil, so it's a very hospitable country. Thank you. So, my job is to talk in general terms about NMES and about the range of clinical situations in which we can use it. And I'm going to try and do some work by putting it in context first. All right. Cool. So I'm from the UK, which is a long way away and very small. And there's a lot of publications around on NMES. I have a database of electrotherapy research, EPA research, and at the moment there's 150,000 papers in the database. So the database is big. This is just a small selection from the database. And okay, so NMES devices can be very substantial, can be very big. They can be NMES can be delivered from multi-mode machines, and NMES can be delivered from very small machines. The NMES you deliver is the same modality. So what comes out from the big machine, the IBRAMED machine, the NMES from here is the same as the NMES from all these other devices. The modality is no different. So we're going to have a look at NMES within EPA. We'll have a brief look at the EPA model, and then we'll look at some basic concepts with NMES and some clinical applications with NMES. As a basic concept, then there is a wide range of modalities we could discuss, wide range of modalities. So on here we have a group of electrical stimulation modalities, and NMES is in here, right? TENS is in here, and interferential and functional stim, and Aussie stim. Aussie stim's in here somewhere, I've lost it. Oh, there it is, Aussie stim is in there. There are lots of modalities, and they are very similar. And other people in the 3-day program will be talking about Aussie stim, high voltage stim, FES stim. So other people are doing details on other modalities. I'm going to try and only talk about NMES. We also have a range of thermal modalities, which we're not touching today, though David Draper will be talking about some shortwave. We also have some low energy modalities, not today. All right? So we're just on one piece of one type of one modality. It's a very limited range. So the basic model for EPA intervention, the basic model is the same for every intervention. So now I'll impress you with the Portuguese slide. I don't know what it says, all right? So it says, in theory, we have a machine, and the machine delivers energy. We push energy into the tissues, and the energy we push into the tissues will activate a physiological response. And we use the physiological response to generate therapy effect. And that's true for ultrasound, that's true for laser, that's true for NMES, that's true for TENS, that's true for shockwave, every modality that's true for. In clinical practice, we don't start with the machine. we don't make our clinical decisions by saying, I have an ultrasound machine, what shall I do? We start with a patient, excuse me, and the patient comes in with problems. So you assess the problems, and that's where you start making your clinical decision. So we have a patient who has had a total knee replacement 4 weeks ago, and they come to see you, and their quadriceps strength is way down. They've lost quadriceps strength, they've lost quadriceps muscle bulk. So in order to be therapeutically effective, we need to decide what's our primary aim. So let's say our primary aim is to increase strength and to increase bulk. All right? That's easy, very simple. So if we want to increase bulk, we want to increase strength, that's our intention over here. So we come one step back through the model, and physiologically, in terms of physiological process, what process do we need to activate to increase strength? We know that process, it's not a secret. So we know what happens in the middle of the model. So if we know what happens in the middle of the model, come one step back through the model, the question is which modality, which type of energy is the best, the most efficient, the best evidenced modality to achieve that effect. And as it happens with my silly example, the best evidence modality is NMES. Well, it would be, because that's today's talk. So if we decide the best modality, that's our number one choice with EPA. Which modality is best evidenced for that effect? If we use ultrasound to increase the strength of the quadriceps, it's not going to work. We know it's not going to work. Ultrasound does not increase muscle strength. It does not mean that ultrasound is useless. It does not mean that ultrasound is not evidenced. It means that ultrasound is ineffective at doing that job. All right? So we'll choose NMES, and when we work clinically, we choose the modality, number one choice, and then we have to choose the dose. How much NMES? What frequency? What setting? What pulse? What machine? We've got to choose the dose in order to be effective. The evidence says we must get the dose right. So in order for your EPA to be effective, whether it's NMES or shortwave or laser or TENS, number one, you must choose the most evidenced modality. Number two, you must get the dose correct. And if you get the modality correct and the dose correct, then it's clinically effective. There is evidence to support therapy. If you choose the wrong modality, or you choose the modality and deliver at the wrong dose, the evidence says you will not be effective. So you must get the choices correct. And then you need to actually deliver the therapy. Delivering the therapy is easy. Getting the choices right is critical. Okay, so if that's true, yes. I don't know what this says either, all right? This translation was difficult. When we try and achieve a physiological response, we've got two options. One option, over this side of the picture, is not subtle. We are using energy and we are forcing the cells to change behavior. The cells do not have a choice. We make the cells do an action. So the modalities that sit there, for example, would include TENS, would include NMES, interferential, and the electrical stimulation. We deliver an electric pulse, an electric current, and as a result of delivering our electric current, our electric pulse, we hit the nerve and we force the nerve to fire. We get an action potential. The nerve doesn't really care very much whether you use TENS or interferential or NMES. There are slight differences between them, which we're all talking about. but your electrical stimulation simply forces a nerve to fire. The nerve has no choice, it must fire. All right? The alternative, and this is not my topic today, the alternative is to use low energy. We don't go in strong, we go in gentle, subtle. And by going in gently, we simply deliver a small amount of energy to the cell, and as a result, we get the cell excited. If we can get the cell excited, it does more work. So if we use ultrasound, ultrasound does not force cells to change behavior. Ultrasound tickles cells, and cells get excited. And laser, and shortwave, pulse shortwave. But that's for other speakers. Today, we're playing on this side. We are using an electrical stimulation. We are forcing nerves to fire. And if we force nerves to fire, something will happen. If we force a sensory nerve to fire, we get a sensory outcome. If we force a motor nerve to fire, we get a motor outcome. It's not difficult. Okay? So, for example, if I use, and I'm not sure how well you'll see this, but if I use a TENS machine, let's do this arm. We'll do a shadow show. All right? So I'm going to use a TENS machine, and I'm going to put it on my arm. Silly experiment. Okay, so this is not a muscle stimulator. This is a sensory nerve stimulator, a TENS machine, which somebody's talking about later in the program. So my TENS machine is going to fire. Whoa, here we go. My TENS machine is going to fire at 1 hertz. So I turn it on. Come on, baby. Wake up. Now my TENS machine has died. Try again. Shall I change machines? I'll try a different TENS machine. Maybe this isn't the TENS machine to buy. Where's my other TENS machine? All right. Right, here we go. Try a different one. Luckily, I have a spare. We have a TENS machine, and we put it on our arm, and we set the TENS machine to fire at 1 hertz, 1 pulse per second. Let's hope this one works. All right. So if I turn the machine on, you see, hopefully you can see, you know what's going to happen. All right. The machine fires 1 time per second. It makes my motor nerve fire 1 time per second. It's got no choice. The nerve can't refuse. The nerve can't say no. I simply force the nerve to fire. Okay? Easy. But this is a TENS machine. This is not a muscle stimulator. The nerve can't tell the difference. The TENS machine is most efficient at stimulating sensory nerves. The muscle stimulator is most efficient at stimulating motor nerves. But a TENS machine will make a motor nerve fire. So if I increase the frequency, of the stimulation, so from 1 hertz, we'll go to 5 hertz. Woo-hoo-hoo! Okay, so my motor nerve is firing 5 times a second. No choice. My muscle is twitching 5 times a second. No choice. So when I do this talk at the university to school children, all I say next is, shall I keep going? Shall I turn it up? And, yeah! You know? So if I go up to 10 hertz, 10 pulses per second, whoa, yes, baby! So my motor nerve is firing 10 times a second, all right? And my muscle twitches 10 times a second. It's still a TENS machine. What happens if I keep going higher? All right? So if I go to 20 hertz, that's boring, because at 20 hertz, the nerve is firing 20 times a second. I know that, you know that. The muscle cannot twitch 20 times a second. So those contractions, those twitches pile up, and Scott was talking about that this morning. The twitches build up, and we have partial tetany. All right? So if I don't touch the machine, I can, oh, a bit too strong. If I don't touch the machine, I can stop that from happening. If I let go, I go back to a contraction. All right? If I turn the machine up higher, that's partial tetany, incomplete tetany. If I go higher, and Scott was talking 40 hertz, 50 hertz, and it's different for everybody. For me, it's round about 40 hertz. I will go to a full tetany. So partial tetany, and now let's go 50 hertz. Whoa, that's tetany, continuous tetany, all the time. That's not nice. I'm just a hero, all right? Okay. There's nothing I can do. That muscle is in tetany. I can't change it. If I turn the frequency up more, so from 50 hertz, I go to 60 hertz, tetany. 70 hertz, tetany. How high does this machine go? 100 hertz. Woohoo! Tetany. 150 hertz. Tetany. Once you've reached tetany, you have reached tetany. All right? And actually, that's enough tetany. That is a TENS machine. It is not a muscle stimulator. You can use any stimulator to make an effect happen. A muscle stimulator, which I'm going to talk about, don't worry, we will talk muscle stim. A muscle stimulator is very efficient at making motor nerves fire. A TENS machine is very efficient at making sensory nerves fire, but they're not exclusive. They can't be exclusive. Okay? Right, let's take the machine off and stop playing games. So, all we're doing with our stimulator is we are using a machine to deliver a pulse, to make the nerve fire, to make the muscle twitch, to have an effect. And all we're doing is we are using that system. It's not difficult. Right, back to English slides now. So I don't know what the Portuguese for Windows is, fenestra or something. Okay. So therapy fenestra, okay? There are windows, there are treatment doses which are clinically effective. And if you take the research evidence, the whole body of research evidence, whether you're looking at ultrasound, muscle stim, TENS, the evidence says there are maximally effective doses. This is the best dose. Maybe this is the best dose for strengthening the quadriceps. Maybe this is the best dose for ultrasound to a ligament tear. Maybe this is the best dose for laser for wound healing. It's the optimum dose. And if you deliver the optimum dose, you get the optimum effect. If you deliver a dose over here or a dose over here, you will have some effect, but you will not have the optimum effect. And when we look at clinical treatment with NMES, or we look at a clinical treatment with any other modality, we are trying to hit our therapy window. That's your preferential dose, your preferred dose. Some of you will have seen this. This is the Arn-Schultz curve. The Arn-Schultz curve always gets shown as a picture to do with laser therapy. This is not a laser therapy curve. This is not a laser therapy law. This is a law of biological response. And the law of biological response says if you deliver your energy, this is increasing energy, this is biological effect. So if we deliver the energy at too low a level, nothing happens. If we turn the treatment up, we turn the dose up, we start to get a therapy effect. If we keep turning the dose up, we get a stronger and stronger and stronger therapy effect. But if we reach this point, this is our maximum effect, our optimum effect. That's the same as my blob in the middle of the diagram. If I have reached the optimum effect and I turn the machine up, I do not get a better effect. I lose the benefit, and we move down here to tissue destruction, tissue damage. So with any modality, whether that's ultrasound or laser or NMES, we are trying to get our therapy dose at the optimum effect. And if you look at the body of evidence will tell you how close you can get. We haven't got all the evidence. Scott was talking this morning that we need more evidence. We do, but we already have enough evidence to help you to get to the top of the curve. And what I'll look at briefly as we go through this session is to have a look at the kind of evidence we've got for NMES in clinical practice and how to try and keep your therapy at the top of the curve. This therapy has an effect, but it's not optimal. This therapy has an effect. It's not optimal. We choose, by choice, we should be up here. And that's all the issue is about electrotherapy. EPA doses is to get you to the top of the curve. Okay, so NMES in general terms, again, some of this is a repeat from Alex, some of this is a repeat from Scott, and some of it will be a repeat later on. There are lots of different names for this modality. NMES is the best general term because people use MES or NMS or chronic NME. There's loads of names, but NMES is a good general term. It's not for a machine, it's just a modality application. We're using long-term electrical stimulation to influence muscle function. And in therapy, most of us use NMES as a way of achieving changes in strength. But you can influence other things. You can influence muscle function, not just strength. There are a lot of studies out there, hundreds of research studies out there, and they would indicate that you can get a change in muscle function with NMES, and part of that relates to changing fiber type activity, and part of that is related to stimulation frequency. Again, you've already heard some of this in Scott's session this morning, so I'm not going to do too long on this one for you. But you know you've got different types of muscle fiber, and it depends on which physiology class you went to and which book you read as to how you name your classification. So some of you might talk about slow and fast fibers. Some of you might talk about red and white fibers. Some of you might talk about type 1, type 2 fibers. Or you might, if you're brave, you might talk about the biochemical pathways. So on the far left there, what we call type 1 fibers, or the SO, slow oxidative fibers, they are the most vascular, they are fatigue resistant, they are sometimes called endurance fibers. They are the fibers you can use over and over and over again. All right? Your type 2 fibers, your white fibers, your fast fibers, and there's lots of different types. I've just put 2 types there. So your type 2A and your type 2B, FOG, fast, oxidative, glycolytic, and fast, glycolytic, FG, these muscle fibers burn glycogen for their energy. They do not need very much oxygen to burn that glycogen, and therefore they produce energy very fast. But when you burn glycogen with a small amount of oxygen, you produce waste material, which we all know, lactic acid is a good example. So these muscle fibers are very fast, high force production, but high waste production. These fibers are slow, they burn oxygen, they do not create metabolic waste, which is adverse, but they don't produce a lot of force. And in your body, and again, Scott mentioned this, in your body, your muscle fibers are balanced around your body for different muscles. So the quadriceps have got a different balance of type 1, type 2 fibers to your gastrocnemius. And your gastrocnemius has got a different balance to your anterior deltoid. It's just what your body needs. All right? That's not new. You know this. All right? So in terms of physiology and in terms of experimentation, one of the first experiments in this area was done by a researcher called Buller way back, 1960. And what Buller was doing in a cat, in lots of cats, in cats, they were doing experiments on a pair of muscles in the cat limb. One of those muscles was a fast muscle, and one of those muscles was a slow muscle. And they were taking the nerve supply to the muscle and switching the nerve supply. All right? So the fast muscle now has a slow nerve supply, and the slow muscle now has a fast nerve supply. And what Buller found was that the muscle changes behavior to match the nerve. Nerve control dictates muscle physiology. Salmons and Verbova, later in the 1960s, 1969, still too early for most of you, but in 1969, Salmons and Verbova showed that you can do that with electrical stimulation. You do not need to cut the nerve. You do not need to move the nerve. You can have the same kind of effect with electrical stim. And that's really the history of this type of activity. It does appear to be possible to get an increase in strength, muscle strength, with electrical stimulation. When I was a student, which was a long time ago, when I was a physiotherapy student, we were told absolutely you cannot increase muscle strength with electrical stimulation. The evidence says you can. The evidence says if you do electrical stimulation and active exercise, you get a best result. The optimum result is electrical stim and exercise. And we were hearing this morning from Jim that EPAs in isolation are not the most effective way to achieve results. This is a great example. Electrical stimulation, NMES, in isolation will increase muscle strength. NMES with exercise gives you a better result. That's what the evidence says. That's what I think the evidence says. Okay, so we've got some work, and we won't do too much detail here. This is just early experiments. This is not with patients. This is with healthy volunteers, athletes. So Hansun Loy does some work, and he has some volunteers, and he divides them into two groups. They all have electrical stimulation to the quads for 3 weeks, and they have stimulation every day for 3 weeks, and he measures their quads change in strength. The volunteers who get the strongest electrical stim have the biggest change in strength. The volunteers with low electrical stim still have an increase in strength, but it's not so much. And again, Scott mentioned this morning, you need to do electrical stim with some strength, some power. What was interesting is that the strength increased over the 3-week period, and at the end of 3 weeks, the stimulation stops, and the strength starts to drop off again. But it takes more than 3 weeks to go back to baseline. So we have baseline strength, 3-week stimulation, increase in strength, stop the stimulation, strength starts to decline, but it takes more than 3 weeks to go back. What Hansein Loy also identified is that he only stimulated the quadriceps on one side, but the quadriceps on the other side also got stronger. That shouldn't happen. You know, if I stimulate my right quads, why do my left quads get stronger? That was a mystery. At this time, 1988, that was a mystery. So, Balogun did the same kind of experiment a few years later, and he did 6 weeks stimulation. He got a 24% increase in strength in the stimulated quads. He got a 10% increase in strength in the not stimulated quads. He was looking for the crossover, and he found it. So therefore, it can't just be a local effect. And a lot of people have looked since, that's early research, and there was a lovely review paper in 2011, and you'll have to write that down because I can't say those names. They're not English. I don't think they're Japanese or something. But these guys identified that the first effect, and again, Scott mentioned it, the first effect was neurological. So your electrical stim has an effect on the efficiency of the neurology. That's your first change in strength. If you keep doing stimulation, you have a neurological effect and you have a local muscle effect as well. But your first changes, your early changes, your fast changes are driven by a neurological mechanism. Spinal cord, spinal pathway, even cortex, not just local. This is one of the early studies where they were doing experiments which were not on patients, but they were not on athletes. These were just healthy subjects. So you get some healthy volunteers, and what you do is you put them all in plaster. So you put them all in a long leg plaster, so from just below the hip down to the ankle, so their knee is completely immobilized. And you leave them in plaster for 6 weeks. All right? You don't break their leg, you don't do any surgery, you don't do anything, you just put them in plaster. So if I put you in plaster, long leg plaster, for 6 weeks, you would expect your quadriceps to get weaker. You'd expect the bulk, the volume of your quadriceps to decrease. That's normal physiology, immobilization physiology. Excuse me. What Gibson found was that he did this to all his volunteers. Half of the volunteers just had plaster. Half of the volunteers had plaster and electrical stim. They cut windows in the plaster, they put the electrodes onto the quads, and they did electrical stim for 1 hour every day while the patient was in plaster. And then when they took the plaster off, they measured the strength, they measured the quadriceps bulk, and there's a lot of results. But the key result is that the group who had the NMES, the group who had the electrical stimulation, did not lose quadriceps strength. The group who did not have electrical stimulation lost nearly 20% of their quadriceps bulk. That's the atrophy loss. All right? So the electrical stimulation prevented the atrophy associated with immobilization. That's an interesting finding, and that's quite powerful, quite powerful. Okay, so if you have a stimulator and your stimulator delivers different kinds of waves, then what do we know about the waves? Scott's mentioned them, Alex has mentioned them, so we'll just have a look and see what we can find. Basically, if you use discrete pulses, you can use the one that Scott was talking about, which is biphasic symmetrical, and you can use biphasic asymmetrical. And Scott showed you that picture and then went past it very fast. I thought he was going to tell you the answer here, but he didn't. Both of these stimulation, both of these waveforms are effective. They are both effective as NMES waveforms. But the evidence probably comes down in favor of this one, the biphasic asymmetric. So if your machine, if your muscle stimulator says, do you want to do biphasic symmetric or do you want to do biphasic asymmetric, based on the evidence I can see, I would use biphasic asymmetric because I think the effects are better. We haven't resolved that one yet. I think there's more research to do. Of course, if you've got an IBRAMED machine with Aussie currents on, you can do Alex's Aussie currents. But if you've got a normal muscle stimulator, and if you can choose your waveform, biphasic asymmetric is clinically effective. Okay, so in terms of the general observations, let's go to the keyboard, Tim. Right, waveforms, observations. Right, you've heard this already this morning, so we won't be too long. We know there's a linear relationship between current intensity and your contraction force. If you turn the current up, the contraction force will go up. And Scott explained about motor unit recruitment, so that's obvious, all right? The greatest effect with the smallest amount of current is achieved with biphasic pulsed stimulation. Alex's evidence starts to challenge that, but at the moment, that's where we think. We think that longer pulse durations are more effective if you want a motor nerve effect. So a TENS machine, my broken one, a TENS machine delivers short pulses because sensory nerves do best, fire best with short pulses. A muscle stimulator delivers longer pulses because motor nerves respond better with longer pulses. And the currents that Scott was talking about this morning and the currents that I'm talking about now, we're using longer pulses. All right? Okay. We know that the stimulation frequency, how many times a second the machine fires, we know the stimulation frequency influences force generation. You saw the frequency curves this morning. Your maximum, and this is some work way back by Binder, the maximum is probably around about 60 to 100 hertz, but that's uncomfortable, that hurts, that's unpleasant, that's a strong tetany. 20 hertz stimulation will achieve about 65% of the force, but it's a lot less fatigue and a lot more comfortable. So if you stimulate at really high frequency with really strong stimulation, you will get a big muscle contraction. But most patients will tell you to stop, because most patients with a real clinical problem, thank you, most patients with a real clinical problem will say no, that ow, that hurts, it's horrible, stop. All right? So if we use lower frequency, and if we use a more gentle stimulation, we still have clinical effect, but without the discomfort. And it may be that the Aussie stim maybe gives us even more clinical effect with even less discomfort. So that's the way to go for the future. Okay. The electrodes, well, you saw me use some electrodes just now. Generally speaking, we're using skin electrodes. We're not using implanted electrodes. There's some talk on neurology, I think it's tomorrow, where we're talking about using FES, functional electrical stimulation, for neurology patients, and some of those patients have percutaneous or internal electrodes. This is not the therapy I'm talking about. I'm just talking about using skin surface electrodes. Most of those these days are reusable electrodes. These are the sticky patches we use. Some people still use the rubber electrodes or carbon rubber electrodes, but most therapists these days are using self-adhesive electrodes. They're most convenient. If you want a simple rule, the simple rule says it's best if both the electrodes are on the muscle belly. If you can get one of the electrodes near the motor point, the outcome is the same. The therapy effect is the same, but you need less current to get the contraction. So if I have two electrodes on your rectus or your lateralis, I will get your lateralis to contract. If one of those electrodes is near the motor point, I will need less current to get the same contraction. And therefore, you will be happier if you know where the motor points are. All right? They're in the books. There's research out there. This is a piece of research from 2011 where they are showing where the motor points are. There is not one motor point. Muscles, this is in the quads, muscles have, this is vastus medialis. So vastus medialis has got two motor points, one about here and one about here. There's not one fixed point. So if you can get an electrode near the motor point, you will get a good effect with a smaller current. So you can either look the motor points up or check them in the textbook or check them in the research papers. So two electrodes, either end of the muscle belly, one near the motor point if you can. Use large electrodes, because if you use small electrodes, you've got a lot of current going through a small electrode. It's very concentrated, and concentrated current excuse me, concentrated current is unpleasant. It hurts. It's irritating. So if your patient is nice and smiles and brings you boxes of chocolates, use a large electrode because it's kind. If your patient is, how do we say a nasty patient? If your patient is not nice, then use small electrodes because it's irritating. All right? That's a joke. That's not serious. Okay? So large electrodes are good. Large electrodes are good. There was some research by Brooks that says if you can, you have an advantage by placing the electrode longitudinally down the muscle you're stimulating. I'm not sure. I'm not sure that that research has ever been replicated, done again. So I'm not convinced that the longitudinal arrangement is critical. The most important thing is to use two electrodes, make them large enough for the muscle you're stimulating, and place them at least one either end of the muscle belly. That's your minimum. If you use those small electrodes I was playing with just now, if you use small electrodes like that to stimulate the quadriceps, that's really unkind. That hurts. So those electrodes are fine. on the muscles on your arm, even on my deltoid, or even on my trapezius, that would be fine. But use those on the quadriceps, no way, because that will hurt a lot. All right? And if you look at the picture up on the top right there, this is using those small electrodes on the quadriceps. It's an advertising picture. It's not a real clinical picture, because that would be very unpleasant. Very unpleasant. Okay. So we know about the motor points. There are some electrodes, and we won't do any detail here today because you probably don't want to know, but there are some electrodes that go in special places, and if you are involved in women's health, you know all about those, and we'll look at them very briefly later, but they're available. All right? Okay, what about machines? I don't work for Chattanooga. I don't work for NRAF. I don't work for any EPA company. So if I'm showing you pictures of machines, they are just pictures of machines. It's not an advert. All right? But on our NMES machines, we have controls. We have things we can set. So what do we do? How do we change those settings? Which settings achieve what? Again, Scott mentioned earlier, you can change the current intensity. Your current intensity, how strong is the current you're delivering? It's obvious, all right? But it's subjective, because the amount of current I need to make my quadriceps contract is different to the amount of current you need for your quadriceps to contract. I don't know about your side of the room, but up here it's hot, all right? I am getting wet, all right? And therefore, if I did electrical stimulation to my quadriceps, I would only need a small current because my skin is wet today. If I was in England, I would be cold, my skin would not be wet, and therefore I would need more current. So English people need more electricity than Brazilian people to have a therapy effect. So we need bigger batteries, all right? You can't say you need 10 milliamps for the biceps and you need 20 milliamps for vastus medialis, because it will vary from patient to patient. You just use the current you need to use to get the contraction that you're looking for. Don't worry about the number, worry about the quality of the contraction you're getting. That's important, all right? You need a good muscle contraction, and Scott mentioned it earlier, and I think we've got some demonstrations coming after me. You need the muscle contraction not just to be a bit of tingling, not just a little bit of twitching. You need a good contraction. You need to tolerate the best intensity that you can, all right? And that will vary a lot between patients. What about the frequency? I showed you just now my silly demonstration of changing the frequency. Scott mentioned the frequency earlier. If you change the stimulation frequency, you change the kind of muscle contraction that you will get. And I think from the research evidence, how strong the current is, current intensity, is really important. And stimulation frequency is important. Those two together really make a difference. We'll have a look at some settings in shortly, but then some machines have got automatic programs on them, and I worry slightly about these automatic programs, because you'll have your machine and you open up the settings and it will say muscle strengthening setting, muscle relaxation setting, and then it will say something about recovery setting, and all these things. Where do those settings come from? They all have different frequencies. The research evidence tells us which frequencies are effective for strengthening, which frequencies are effective for pain relief or for endurance capacity. The settings on your machine may be correct, they may not be correct, so be very careful with the automatic settings on machine, because they're not guaranteed to be correct. We'll look at some numbers later on. We know different muscle fiber types respond best to different frequencies, or we think we know different fiber types respond to different frequencies. If I was going to buy a stimulator, at the moment, with the evidence we have, I want my stimulator to be able to go down as low as 10 hertz. And I want my stimulator to go up as high as at least 50, maybe 60 hertz. That's my range to be clinically effective. And ideally, you should be able to set that machine, not just automatic programs. The duty cycle, you've heard about it already today. The duty cycle, how much of the time the machine is on and stimulating, how much of the time the machine is off and delivering no stimulation. So on my picture here, my stimulation comes on, nothing, 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 nothing. Here it comes again, and the rest, nothing, 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 nothing. I hope the translation is good. Have you got a fast translator? Shall I do it again? Okay, so your stimulation phase is on, contraction, and then you have a rest. Your duty cycle is the ratio, the percentage between your on time and your off time. Some machines describe this as a percentage. Some machines describe it as a ratio. So in this case, let's say we go on for 10 seconds and we go off for 20 seconds. So as a ratio, that's 1 to 2. As a duty cycle, that's 33%. So your duty cycle controls how much time is on, how much time is off. That matters. That matters clinically because you need to get that right. So your duty cycle, your minimum, I think from the evidence, your minimum is to use equal cycles. 10 seconds on, 10 seconds off. 10 seconds on, 10 seconds off. And you would only do that if the muscle was in good condition. Late rehab, reasonably good muscle. The more weak the muscle is, the longer you leave your rest phase. So for a really weak muscle, let's say my pretend patient with the weak quadriceps who's had a knee replacement, I might do 10 seconds on and 90 seconds off. All right? So let's just try, because if you just think about this, 10 seconds on, it's coming on now. So that's 1, 2, 3, 4, down 6, 7, 8. That's only 5, 6, 7, I can't count. 8, 9, it's still on. 10, stop. I've now got 1.5 minutes, 90 seconds of no stimulation. I'll have a cup of coffee. All right? I'm busy. I can't take the call. So you have 10 seconds on, 90 seconds off. But in a weak muscle, that's good because it gives the muscle time to recover before you hit them with the next stimulation. If you do too much stimulation, you will stimulate a fatigued muscle. And if you want to damage muscle with NMES, you do strong stimulation on a fatigued muscle. It will cause muscle damage. So you need to make sure the rest period is long enough to get recovery. The ramp, I've shown it on the picture. Scott mentioned it in passing. The ramp is where you gradually increase the stimulation. When you make your muscle work, you never go from nothing, 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 fully contracted, contraction, contraction, let go. You don't do that. You build the contraction up, you hold the contraction, and you let the contraction go. And the ramp control on your machine is a way of copying the physiological response. So you can set your ramp up, the build up of the contraction. You then have a sustained period where the contraction is on, and then you have a ramp down where you let the contraction go. And for example, if I was doing a 10-second stimulation, I might do 2 seconds to build up, 7 seconds to hold the contraction, and 1 second to let the contraction go. That, if you're a patient, that's much more comfortable, much more acceptable. And even on the simple machines, you can control ramp up and ramp down. And if you're a patient, you will appreciate that a lot. Clinical parameters? Well, if we look at a really simple muscle strengthening protocol, the general evidence, this is not from one research paper, this is looking at a body of research papers. The general kind of parameters which will be effective for a strengthening outcome would be to use a stimulation frequency between about 30, 35 hertz, somewhere around there. You use long pulses, 350, 400 microseconds. Scott mentioned those earlier today. Your minimum setting is to stimulate on for 4 seconds, followed by 4 seconds rest. So 4 seconds contraction, 1, 2, 3, 4, let go, 4 seconds rest. That's your minimum. Most people use longer stimulation phases, and typically 8 seconds, 10 seconds, that's the duration of your on phase. You need at least 15 minutes on alternate days. So 15 minutes today, nothing tomorrow, 15 minutes, nothing the next day. That's your minimum. Most of the effective clinical research papers use more than that. A lot of research, and Scott looked at some earlier, I'm going to look at some soon, where they may be doing 30 minutes every day. Maybe they're doing 30 minutes, 15 minutes in the morning and 15 minutes in the afternoon, twice a day. If you want your minimum effective dose, I think 15 minutes alternate days is your minimum that's worth doing. And you need a strong enough contraction to get a therapy effect. Now that's very, very general. But if you had a very simple muscle stimulator and you were going to set the machine, that's the kind of settings you could use, whether you're doing the quadriceps or the deltoid or the glutes or the soleus or the whatever, the abdominals. All right? That's a general setting that should work across. If you've got a clever machine, if you've got a specialized machine, you can be more effective than that. But that's a basic dose which will have, which will be clinically useful. Okay, let's leave off the endurance. So let's look very briefly before you all go to sleep. It's too hot in here. We'll have a look at the range of clinical practice with some evidence. There are lots of references on here. I have probably in NMES research, I think I have 7,000, 8,000 references. So this is not 8,000 references. This is some recent research. It's not the whole thing. So, very briefly, we'll look at these areas. Muscle stimulation after joint replacement, after arthroplasty, after other kinds of surgery, with osteoarthritis, pain, function in osteoarthritis, incontinence. We were not doing much on incontinence today. Interesting area over here with serious illness, COPD, heart failure, cancer, good research. And then neurology, I'm not doing much on neurology because you've got some very clever neurology talks coming tomorrow. So I'm just doing the simple talk. The other people are doing clever things. All right. Okay, so let's start with the arthroplasty, the joint replacement. This is nearly all done on knees. Most of the arthroplasty research has been done with knee replacements, and it's nearly all done with the quadriceps as the target. There is some work being done on the hip. There is some work on the shoulder, but nearly all of it at the moment is knee. Wrong way. So, if we can come up with a slide, the first study on there we're going to look at, but you've already heard mentioned, excellent research study from 2012 by Stevens Lapsley. We'll look at the details. I'll pick on that one. All right? But there are lots of others. There's this is electrical stim for orthopedic implants. So that's an interesting paper because some of you may have been told when you did your physical therapy or physiotherapy training, you must not do electrical stimulation when there is metal in the tissues. It's a contraindication. It is not a contraindication. If you have a knee replacement and you want to do electrical stimulation, it's not contraindicated. If you've got a nail or a wire or a screw in your tissues and you want to do electrical stimulation, it's fine. It's not a contraindication. All right? There are some things which are pacemakers. That's a contraindication, but a knee replacement is not. Anyway, there's lots of research. So this is just some of the recent research, and there's some more. These are all NMES treatments. They are all NMES treatments with arthroplasty. They are all on the knee. They are all positive in their support evidence. All right. So this is the study by Stevens Lapsley that got mentioned this morning. This is 2012, so it's a modern research paper. It's a clinical trial, randomized controlled trial, and it aimed to evaluate the effectiveness of stimulating the quads with NMES starting 48 hours after the surgery. So this is not 3 weeks later, 6 weeks later. This is 2 days post-op. So there were a good number of patients, 66 patients. They were all having a single knee surgery, divided into 2 groups, standard rehab plus NMES. You heard that this morning. 48 hours post-surgery is when they started. Twice a day, maximum tolerance intensity. You turn the machine up as much as that patient can. And it will be different for every patient. But you turn the stimulation up so it's strong. 15 contractions with a portable stimulator. They were using biphasic symmetrical at 50 hertz. Fairly typical stuff. 15 seconds on, 45 seconds off. These patients did not have good quadriceps. These patients had bad knees. They were going for surgery. So their quadriceps were not good. So they were doing 15 seconds on, 45 seconds off, and they're doing that 15 cycles, and they're doing that twice a day. And they were then checking their outcome measures at 3 weeks, right up to 1 year. So it's a long follow-up experiment. You can just see, sorry, it's not a good picture, but this is from the journal article. You have big electrodes on the quadriceps. So this is the patient. I'm not a lady, but that's a lady. Okay, so she's sitting there, and you'll look at your picture is taken this way round. So that's a big electrode at the top of the quadriceps, big electrode at the bottom of the quadriceps. That's kind, because big electrodes are not irritating, right? And that's just the research protocol. They measure strength, they measure time get up and go, which is a function test. They measure stair climbing, they measure walking test, pain, movement, and WOMAC, function. And all of that lot were measured, lots of results, but the summary results are like this. The quadriceps and the hamstring strength were greater in the stimulation group. Remember, this group has had stimulation and standard therapy. They have a better quadriceps strength and a better hamstring strength than the standard therapy group only. NMES does not replace standard therapy. NMES is an adjunct to standard therapy, which is exactly what you were hearing this morning, and exactly what Jim was suggesting, that EPAs are used in conjunction with your therapy, not instead of therapy. They got a better result for the walking test, they got a better result for the stair climbing test, they got a better result for the 6-minute walk test, and that was at 3 weeks, and the improvement was still there 1 year later. That's a very good result. Very good result. All right? There are lots of studies like that. That just happens to be modern, it happens to be new, it happens to be 2012, but it's a good example of muscle stim to the quadriceps after knee replacement surgery. So what about other surgery? We'll speed up a bit because you're going to lose the will to live soon. So what about other surgery? There are lots of examples, and some of these I put on here were after NMES, after anterior cruciate, anterior cruciate, anterior cruciate. If a patient has had anterior cruciate surgery, they need recovery, they need rehabilitation. So the research question is, if you add NMES to their recovery program, do you get a better result? Does it make a difference to the outcome? That's the research question. And there's more, and we can do hundreds of these. So we'll pick on one. This is a study by File, 2011, so it's a recent study. American Journal of Sports Medicine, so it's a big journal. This was the same kind of idea, using NMES in addition to a standard rehabilitation program. All right? So it's not NMES or standard rehab. This is NMES plus standard rehab. Does it add to the value of rehab? And by a range of authors. Okay, so it's a randomized trial. You've got 2 groups of stimulation and a control group. So your patients, and there's 96 of them, are divided into 3 groups. 1 group gets standard rehab only. 1 group gets standard rehab and this type of NMES, and this group gets standard rehab and this type of NMES. We're comparing 2 different NMES protocols. The stimulation is delivered 3 times a day for 5 days a week for 12 weeks. The patient does not come into therapy for this treatment. The patient has a small stimulator. The patient takes the small stimulator home, and they do this as home therapy. It's not instead of physical therapy. It's a home treatment in addition to physical therapy, physiotherapy. Okay, So what happened? What happened in the study? The stimulator, we've now got the picture the other way round, so you're looking, the picture is taken looking down on the knee. This is one of the stimulations. The NEHAB is a stimulator which is built into like a sleeve. So you pull the sleeve on and the electrodes are in the correct place. All right? The stimulator is built into the sleeve. This is not an advert. This is the research that was tested. All right? So the NEHAB, this stimulator, 50 hertz, 10 seconds on, 20 seconds off, 1.5 seconds ramp up, 1 second ramp down, 20 minutes. The other stim is a normal stimulator, and it delivers 50 hertz, 5 seconds on, 10 seconds off, ramp up, ramp down, 20 minutes. But remember, this is 20 minutes 3 times a day. And they measure the outcome. That's where the electrodes are. If you want to know the details, you can read the research paper, but we know where the electrodes are, and we know that we can copy that electrode position. That's easy. All right? The summary of the results, looking at the strength changes measured at 2 different angular velocities, 90 degrees a second, 180 degrees a second. In the NEHAB group, they have got a 30% increase in strength at 90 degrees a second and nearly 30% increase at 180 degrees a second. That's good. The other stimulation, the standard stimulation group, have got an improvement in strength, but it's significantly lower than the NEHAB group. And the control group, who have just standard treatment, no stimulation, they get a change in strength. But the ordinary stimulation and the control group are not, there's not a lot of difference. The advantage appears to be, for this trial, the advantage is that the garment stimulation is good in this research. I'm not saying you should buy a garment, I'm saying the garment research here was having a stronger effect. Okay, so we can do knee replacement surgery, we can do ACL, anterior cruciate surgery. What about osteoarthritis? Is there any evidence for using NMES with osteoarthritis? Yes, there is. Yes, there is. There's lots of it. So we can use quadriceps again with OA knee, electrical stim, osteoarthritis, etc., etc. There's lots of papers. We'll look at one. This is a paper by Gaines. This is not so new. This is 2004. And Gaines in 2004 is using muscle stim for patients with arthritis knee pain. These are all old patients, even older than I am. All right? These are really old patients. And they're looking at short-term effect and long-term effect of muscle stim, 12 weeks home stimulation over the quadriceps for these patients. Smaller study, 38 patients. They either had NMES muscle stim plus education or education only. That was the comparison. If you add muscle stim to the education, does it give you a better outcome? That was their research question. They've measured pain, they've measured diary pain, they've measured arthritis impact scale, they've measured a lot of things, all right? Mainly pain. The stimulation group, the ones who get the NMES, have a significant reduction in pain after the treatment. So this is not TENS. This is a muscle stimulating treatment. But when you do a muscle stimulating treatment, the pain in OA knee reduces. The arthritis knee pain reduces when you make the muscle work. This is not instead of this is not a replacement for therapy. This is a home addition to therapy in order to gain advantage. But please don't think that I'm suggesting, and don't think that anybody is suggesting, this is a replacement for physical therapy, because I don't think it is. It's not a replacement. So the stimulator they were using was using symmetric biphasic stim, 50 hertz, 10 seconds on, 50 seconds off, with a ramp, 15 minutes a day, 3 days a week, 36 sessions. All right? And there's some other details there. That treatment is easy to deliver at home. You do not need a big, expensive treatment device, because a small muscle stimulator will deliver that very easily. So you don't need big, expensive devices. You need a small device, and you need to know what the evidence says to do with the small device, which is easy. Okay, so there's other studies. We won't go through them because we're running tight on time here. This is a study, another 2004 study by Callahan and Oldham, and they were looking at quadriceps stimulation for patients with OA or patellofemoral pain, and you can check the research. What they found was, on that research, that the patients who had the stimulation, they had two different stimulators, but they were effective. Their comparison was between a very expensive stimulator and a very inexpensive stimulator, so expensive and cheap. And they were comparing, does the expensive stimulator give you a better effect? They were both effective. There was no advantage to the expensive stimulator. So you do not have to spend big money to have therapy effect. You need to know how to set the machine. Incontinence, lots of research on incontinence, which we're not doing today, but there's lots of it there. So the last ones, very quickly, and these you may not be familiar with this research. All right? You can use NMES as a stimulation to help patients who have severe end-of-life disease. So COPD, chronic obstructive pulmonary disease, heart failure, and muscle weakness with cancer. Lots of research, and we don't routinely treat these patients with NMES. But patients with COPD, patients with chronic obstructive pulmonary disease, their quality of life severely reduced. Their muscle strength is severely reduced because of their respiratory problem and because they have very limited mobility. They can't walk for a long distance because they lose their breath. They become breathless. So if you do NMES to patients with COPD, so you do muscle stim to patients with severe respiratory disease, can you help to reduce their muscle weakness? You've got patients with heart failure who can't undertake big exercise. Can you do NMES to a patient with heart failure to limit their muscle weakness? And some work on cancer, patients with cancer on chemotherapy. The chemotherapy makes them ill. When they are ill, they lose muscle bulk. They lose muscle strength. So can you use muscle stim to limit the the bad effects of chemotherapy on muscle strength. This is what all this research is about, and there's plenty of it. So we'll look at two very quickly, then I'll wrap it up. All right. This is a study by Muir in 2004. Muscle stim to the thigh in patients with advanced chronic heart failure. This is not our normal muscle stim patient. So they did this in their patients. They investigated, can we limit the change? Can we limit the loss of muscle? All right. So they have 32 patients in a treatment group and a control group, and they went through the research and they measured VO2 max, work capacity, walk, and muscle biopsy. Went through lots of tests. The peak VO2 increased in the stimulation patients. They got an increase in their ability to do work. They had an increase which was not shown in the control group. So the muscle stimulation to the quadriceps has a real effect on patients with heart failure. Their ability to work, I don't mean a job, I mean work as in carry out physical activity, increases, and in fact their quality of life increases because you've helped to maintain their muscle. That's potentially is very valuable. They were doing stimulation every day. There's a review in press, and I can't give you the reference because it's not published yet. This is very, very new, nearly published, but it's a very good review. This is muscle stim for adults with cancer. The muscle stimulation is not to treat the cancer. The cancer is treated with chemotherapy. The chemotherapy brings about muscle wasting. So the muscle stim, the NMES, is to limit the muscle wasting. And this is a systematic review. It's not one piece of research. This is a systematic review for a range of patients. There are 11 studies included in this review and 218 patients. And what they showed was that their quadriceps strength was significantly improved with muscle stim. Their walking was improved. Their walk test time was improved. Their shuttle walking was improved. So therefore, all the functional measures for this group improved with muscle stim, which is that's good. It's a good result. Okay, neurological patients I'm not doing because we've reached the end of time, and Therese is doing some work on muscle stim and neurological conditions tomorrow, so I don't want to steal all her best evidence. But all of those groups have published research evidence to support the use of NMES, and all of those groups you have demonstration of clinical value, not just statistical value, but clinical value. So my conclusion, that's all stroke patients, stroke patients, stroke patients. My conclusion would be NMES does stimulate muscle. You saw it earlier, and where's he gone? Scott was talking about it. We know the kind of stimulation parameters which are most effective. We should, with more research, we should get closer and closer to the optimal effect. But we do already know approximately where the best effect is. More research will get us closer. But at the moment, there is already evidence of clinical value, and the evidence is published, and it's randomized controlled trials It's good evidence. It's hot. I'm English. Thank you very much. That'll do.